Hey everyone, this is Rebekah, nurse practitioner with the cardiology group. I am going to be giving you guys a guideline review of the 2019 ACC AHA guidelines for primary prevention of cardiovascular disease. And just a little background information before we dive into the guidelines. Primary prevention means that a patient has not been diagnosed with cardiovascular disease. The purpose of primary prevention is to reduce the risk of having cardiovascular disease. Cardiovascular diseases include coronary artery disease, myocardial infarctions, cardiomyopathy, heart failure, and peripheral arterial disease. However, most of these guidelines are also used with the secondary prevention of CVD. So once diagnosed, we optimize these guidelines to hopefully prevent further progression of the disease. The main goal of this review is to empower the frontline staff, our medical assistants and nurses to have evidence-based information to help educate our patients. These patients get to know and trust you as the frontline providers and may ask you questions over asking the provider questions. As much as we would like a quick fix, rather than modifying our diet or exercise, promoting a healthy lifestyle truly is the most important way to prevent cardiovascular disease. Just a quick overview of the topics to be discussed in the tools for prevention. We're going to go over a heart-healthy diet, exercise, tobacco cessation, cholesterol management, blood pressure management, diabetes management, and the prescribing of a low-dose baby aspirin. Heart-healthy diet. We've heard it said time and time again, but a heart-healthy diet is important in primary prevention. We want to educate our patients to focus on the intake, of course, everything in moderation, but focusing primarily on the intake of vegetables, fruits, nuts, whole grains, and lean proteins. Lean proteins include lean vegetables, lean animals, and fish. We want to reduce the intake of red meats, processed meats, refined carbohydrates, and sugary beverages. Obesity significantly increases cardiovascular risk. Therefore, encouraging weight loss if overweight or obese is really important. This information can be used to provide our patients with exercise recommendations. 150 minutes per week of moderate intensity exercise. Activities considered moderate intensity is a brisk walk or biking. A good rule of thumb is if you can carry on a conversation easily, but may sound a little winded, it's considered a moderate intensity activity. If you enjoy vigorous intensity activities, such as running or cycling uphill or greater than 10 miles per hour, you only need 75 minutes of activity per week. And I say 75 minutes, that's at least 75 minutes. If you can't speak but a few words before having to take a deep breath, it's likely a vigorous activity. Or the patient is deconditioned, and we really need to encourage some form of exercise and building up to at least 150 minutes per week of moderate intensity activities. Even modified exercise in those deconditioned patients are better than nothing. Probably the most crucial modifiable risk factor is encouraging tobacco cessation. Smoking significantly increases cardiovascular risk by 2 to 4 times, even in social smokers. However, just 1 year after smoking cessation, you reduce your risk of MI. 2 to 5 years after smoking cessation, the cardiovascular risk of tobacco use is almost reduced to that of a non-smoker. Smoking causes damage to the blood vessels and causes them to thicken and narrow, resulting in increased blood pressure and workload of the heart. This cannot be reiterated enough to our patients who continue to smoke. We've actually seen an uptrend in those smoking recently, so we really need to encourage that smoking causes damage to more than just your lungs and that it's a very important habit to stop. The next 2 slides we're going to discuss deal with a cardiology practice. We deal with in a cardiology practice daily. Hyperlipidemia and hypertension are the 2 most common things we see in our patients. Not surprisingly, these can be directly correlated with diet and exercise. Some of our other providers will discuss these in greater detail in subsequent lectures and dive deeper into the treatment guidelines. Just know that we use guideline recommendations when treating these patients. These guidelines are ever-changing and new information becomes available almost yearly, so these may change within the next year. For now, these are the guidelines that we're going to go over, though. When it comes to cholesterol management for primary prevention, our goal total cholesterol is less than 200, and our goal LDL is less than 100. However, once diagnosed with cardiovascular disease, The goal LDL is then reduced to 70, which is the pack for most of our patients. That is, unless you have cardiovascular disease and diabetes, then the goal is even more stricter for LDL, and that's around 55. Just as cholesterol guidelines change, so do blood pressure guidelines. Previous goal blood pressure used to be less than 140/90. However, with the most up-to-date guidelines, goal blood pressure is now less than 130/80. Previous guidelines had a pre-hypertension category and adjustments of goal blood pressure based on age. Those modifications are now gone. Goal blood pressure for everyone is now less than 130/80. One of the resources we can provide our patients regarding reducing blood pressure is by educating them on the DASH diet. It's the dietary approach to stopping hypertension. Sodium restriction is the first line to reduce blood pressure without medication. Not only is CVD the most common complication of diabetes, but it's also the leading cause of mortality from the disease. The goal hemoglobin in the diabetic patient should be less than 7%. Metformin is used as a first-line drug, but more recently, the SGLT2 inhibitors, such as Jardiance and Farxiga, are now marketing their indications for use in reducing cardiovascular disease. There are many recent studies out regarding SGLT2 inhibitors, and more information becomes available almost daily. One of the last topics of primary prevention is regarding low-dose aspirin use. As you can see, there are recommendations on who should be prescribed aspirin and who should not. This is from the recommendation for an 81 milligram baby aspirin. There is no benefit in taking 325 milligrams over 81 milligrams for CVD. Of course, there are exceptions, but for basic purposes, no 81 milligram baby aspirin. The following are the recommendations of when aspirin should or should not be used. Low-dose aspirin might be considered for primary prevention of ASCVD in select higher adult aged 40 to 70 years who are not at an increased bleeding risk. So in our office, we use the ASCVD risk calculator to determine their 10-year risk and if a low-dose aspirin should be used. Low-dose aspirin should not be administered on a routine basis for primary prevention among adults greater than 70 or among adults at any age who are at an increased risk of bleeding. Low-dose aspirin is utilized as a secondary prevention in those with CAD in almost all cases, unless there is clear contraindication. We pretty much use aspirin in most of our patients because we're treating secondary prevention, but for our patients who have undiagnosed or not previously diagnosed with coronary disease, we do most of the time also give an aspirin. All right, so putting it all together, our patients trust you and you are the first line of communication. You can utilize the guidelines to help educate our patient with the most recent up-to-date information. By doing this, you are helping prevent one of the leading causes of death, which is cardiovascular disease. So the next slide will be the resources you can use to provide with the patients to go to the tobacco quit line, to go over the guidelines for blood pressure and cholesterol management.